That's done. Um, all righty. So once again, we said the chief complaint is that the patient needs risperidone to be reordered, and she reports that she is unsteady on her feet. Um, history or history of the chief complaint: the patient was started on risperidone, zero point 0.5 milligrams BID 6 months ago by her previous psychiatric provider for aggressive behavior, scratching, biting the workers at her day program. After starting with Spiridone, she was able to interact more appropriately at the day program without any aggressive behavior. Um, Her guardian is concerned now because she's unsteady when walking, and he reports that she has to hold on to the walls. So, undoubtedly, she had some behavioral issues that responded to the intervention, but now she's having um, a side effect. Past psychiatric history: no known history of hospitalizations or suicide attempts. She was diagnosed with charge syndrome, um, and has had a series of guardians. Now, charge syndrome, CHARGE, is a genetic disorder. It includes various pathologies, uh, columba in the eye, which is a hole in the iris. There's some cardiac defects. Uh, there's some uh, dysmorphia of the ears. And of course, there's some cognitive issues with that. Um, she's currently in a supervised day and work program. Uh, uh, she has limited history. There was limited history was obtained due to the guardian's lack of information and the patient's inability to communicate effectively. Medical history. Once again, she's diagnosed with charge syndrome, according to the patient's guardian. Currently, she's being prescribed metformin, unknown dosage. Her caretaker reports that her blood sugar is within normal limits. She's 4 feet 8 inches tall, and she weighs 120 pounds. History of drug or alcohol abuse: there's none. Family history: the patient was adopted as an infant by an African American family. The adoptive mother died when the patient was 16 years old. Um, an adoptive sibling took care of the patient until 3 years ago, when that sibling passed, and now she's under the care of her other adoptive sibling, who is her guardian. Personal history: perinatal. There's no information, as the patient was adopted as an infant. Childhood: there's no information known by the guardian. Adolescent: the patient's adoptive mother died, and the patient was taken care of by a sibling, as stated before. Adulthood: the patient has limited intellectual capacity and requires full assistance with activities of daily living. Trauma or abuse history: there's none known. Um, all right, we'll move on to the mental status examination. Appearance: she's well groomed, small stature. She tilts her head to the left and is smiling. Um, do this right here. Um, uh, Behavior and psychomotor activity: she's cooperative, leans forward when walking with short, shuffling steps. At the previous two visits, the patient's gait was noted to be normal. So this is a difference. Consciousness: she's alert. Um, Orientation: she's not oriented to time or place, but responds well to her name. She knows that it is Christmas season and that it's raining outside. Uh, she repeats comments in a perseverative manner. Memory: she remembers her writer's name. She remembers the clinician's name. She's able to state the name of some limited objects that are in the room. Concentration and attention: the patient is easily distracted by objects in the room. Visual spatial ability was not assessed. Abstract thought: not evident. Intellectual functioning, um, severe to moderate intellectual impairment, but she is able to follow simple commands. Speech and language, she does have spontaneous speech. She's able to form short sentences, but most responses are only one word, and she's slightly loud with that. Perception, there's no evidence of any abnormalities. Thought processes, she's perseverative about the rain outside. She kind of stays on that. Thought content, she says repeatedly, it's raining outside. Suicide, suicidality and homicidality, none. Mood, it's euthymic. Her affect is congruent to her mood. Impulse control, she interrupts when others are speaking, but can respond to redirection. Judgment, insight, and reliability, all are limited by her intellectual capacity. All right, so let's formulate a diagnosis. Which diagnosis should be considered? The author here presents three diagnoses. The first one is intellectual disability. Um, the second is impulse control disorder, and which is unspecified. And the third one is neuroleptic induced Parkinsonism. And we'll go ahead and start talking about the intellectual disability. So, the diagnostic criteria for intellectual disability is um, a disorder with onset during the developmental period, meaning that it occurs early in life as one is acquiring uh, increasing their cognitive capacity. And this includes both intellectual and adaptive functioning deficits in conceptual, social, and practical domains. Um, there are deficits. There are three criteria. A, there's deficits in intellectual functions such as reasoning, problem solving, planning, abstract thinking, judgment, academic learning, and learning from experience. That can be confirmed both by clinical assessment and individualized, standardized intelligence testing. B, there's deficits in adaptive functioning that result in failure to meet developmental and social cultural standards for personal independence and social responsibility. Without any ongoing support, the adaptive deficits limit functioning in one or more activities of daily living, such as communication, social participation, independent living, um, and these occur across multiple environments such as home, school, work, and the community. And C, there's the onset of intellectual and adaptive deficits that occur during this developmental period. And there's certain specifiers here: mild, moderate, severe, and profound. Um, you can address these either quantitatively or qualitatively. Uh, most the what we're doing now is really addressing these specifiers more qualitatively, based upon functioning as opposed to the numeric based on IQ testing. But um, normal is anything above 70, mild is 55 to 70, moderate is 40 to 55, severe is 25 to 40, and profound is less than 25. But once again, what we're doing currently is just addressing these degrees of severity based on qualitative or clinical analysis without any type of measured intelligence testing. So, what is the rationale for this diagnosis? All right. The levels of severity of intellectual disability are not defined by IQ scores, but by the individual's adaptive functioning, which I just stated. This patient meets the criteria for severe impairment because of the following. So she's in the severe category. She has in the conceptual domain, she has little understanding of written language, numbers, quantity of time or money, um, and her caretaker provides most support for any problem solving for her. In the social domain, her language is limited. Her speech includes predominantly one word or one phrase responses. Uh, she finds pleasure engaging with others. Uh, However, and in the practical domain, she requires support for all of her ADLs and requires supervision all of the time. She does have a concurrent diagnosis with this, uh, assigned with this intellectual disability, which is charge syndrome, um, and that's been reported by the caretaker. It is presumed that genetic testing was completed in order to specifically identify this genetic disorder. Previous medical records would need to be obtained to verify this diagnosis. However, this condition has significant implications for cognitive functioning and physical health. All right. What tests or tools should be considered to help identify the correct diagnosis here? A thorough psychiatric evaluation with mental status examination uh, is sufficient to diagnose this patient with intellectual disability. If the patient was higher functioning and there were some questions about her intellectual abilities, a Montreal Cognitive Assessment (MOCA) could be completed. Um, However, she would not be able to complete this assessment due to her low cognitive functioning at this time. Alrighty, we're going to move to the next diagnosis, which is unspecified impulse control disorder. This category applies to presentations in which symptoms characteristic of a disruptive impulse control or conduct disorder that causes clinically significant distress or impairment in social, occupational, or other areas of functioning predominate but do not meet the full criteria of the disorder in any disruptive impulse control or conduct disorder diagnostic class. So it's unspecified. The unspecified impulse control disorder category is used in situations in which the clinician chooses not to specify the reason that the criteria are not met for a specific impulse control disorder, and includes presentations in which there's insufficient information to make a more specific diagnosis. So let's go look at the rationale for this diagnosis here. The patient's history indicates an impulse control disorder because her symptoms of scratching, um, biting the workers at her daycare center, and and this caused clinically significant distress in this important area of functioning. Her symptoms um, do not meet the criteria for any other disorders in this category. It is not possible to specify the reason that this patient does not meet the criteria for other disorders in this category due to limited information available. Therefore, a diagnosis of unspecified impulse control disorder is chosen. Impulse control disorders are common comorbidity with people, individuals who have intellectual disability and who may exhibit aggressive or self-injurious behaviors. It should be noted, however, that poor communication skills may be a major factor contributing to aggressive behavior in individuals with intellectual disability. So, and another thing to consider when people are a little they're acting out is the fact that they may be, and because they have poor um, communication skills, there may be something they may be in pain, and that's one of the things you got to look out for. There may be some type of discomfort, physical discomfort, that may be making them agitated. So before you would really want to medicate something like that, you would want to do a thorough medical evaluation to see if there was some physical or medical condition that's causing the agitation, and then address that. And then you can treat the situation with psychotropic, and even before that with some behavioral intervention techniques. Um, The third diagnosis is neuroleptic induced Parkinsonism. Um, because of the unsteady gait, Parkinsonian tremor, muscular rigidity, akinesia, loss of movement, or difficulty initiating movement, or bradykinesia, which is slowing of movement, develops within a few weeks of starting or raising the dosage of any neuroleptic medication, or after reducing the dose of a medication used to treat the extra pyramidal symptoms. So if you have a neuroleptic and you're increasing it, it can cause EPS, or if you have a medication to treat to manage the side effects of a neuroleptic, reducing that medication can bring on the Parkinsonian syndrome. So, what is the rationale for the diagnosis here? The development of slow shuffling gait, poor balance, with a tendency to lean forward, or symptoms resembling Parkinsonism that developed after taking the risperidone for several months. The neuroleptics with their dopaminergic or anti-dopaminergic effect, um, dopaminergic lowering or anti-dopaminergic effect, have been known to cause this pseudo-Parkinsonian symptoms. Um, what tests or tools would you uh, considered to use to help identify this diagnosis? The Ames test, abnormal involuntary movement scale. This test is used to detect movement abnormalities, particularly tardive dyskinesia in patients taking neuroleptic medications. Um, but going through the test, you can also see if the person has some signs of Parkinsonism. Um, but obviously, just watching the patient walk, sit, um, stand erect from sitting, uh, um, shaking their hands, looking for some cogwheeling rigidity, all of that can help you confirm the diagnosis of um, neuroleptic induced Parkinsonism. What differential diagnosis should be considered here with this diagnosis? Actual Parkinson's disease, idiopathic. If the patient's movement symptoms do not decrease with the lowering of the risperidone, Parkinson's disease should be considered, and a referral to a neurologist would then be indicated. Um, Possible medical comorbidities should be ruled out, as certain conditions may contribute. Other medical conditions may contribute to the Parkinsonian presentation. So once again, just go back to the just doing another medical evaluation to see what else could be going on here, um, other than the neuroleptic medication itself. So let's move on to formulating a treatment plan for this particular patient with these three diagnoses. So, which treatment would you prescribe, and what is the rationale? Psychopharmacology, one you would want to reduce. Here it says you would want to reduce the risperidone to 0.25 milligrams BID. Risperidone is indicated for the impulse control problems, but the dose should be reduced due to the Parkinsonian type symptoms. I That would be one thing to do, but in a person who's intellectually disabled, I probably would move them to a different a different neuroleptic, something like Seroquel or Zyprexa, um, and maybe something even in between that may not be so sedating and may be a reason for them to fall, but not strong enough to actually create the Parkinsonian symptoms. So I try some low dose Seroquel, Zyprexa, uh, as opposed to the lowering the dose. But either way, it's prudent. Um, Referrals, a full medical workup should be conducted to evaluate for any medical comorbidities that may contribute to the mood, motor, or impulse control issues. Additionally, a full cardiovascular workup should be conducted because individuals with charge syndrome have a high incidence of cardiovascular disease. type of psychotherapy, supportive therapy for the family member, guardian should is indicated. Psycho psychoeducation. The guardian should be referred to the Charge Syndrome Foundation, which can be assessed at www.chargesyndrome.org. Um, the caretaker should be educated about preventing falls until the patient's gait becomes more steady. For instance, showering without assistance, walking up or downstairs, or walking for long distances should be avoided until her gait is more stable. Um, what are some of the standard guidelines we would use to treat or assess this patient? Uh, there's a standard guideline called the Guidelines for Understanding and Serving People with Intellectual Disabilities and Mental, Emotional, and Behavioral Disorders. Um, um, and that is out of the Florida Developmental Disabilities Council. So they have a nice pamphlet on how to manage these disorders through and through. Uh, Clinical notes: individuals with intellectual disabilities may have difficulty adjusting to changes in their environment, including changes in the staff at their day programs or respite programs. Therefore, inquiries should be made to assess for any of these changes. So you have several things that could, as far as the behavioral component, the agitation, pain, staff changes, a particular staff, or just changes in the environment. So all of these things need to be addressed when you're treating behavioral disturbances in folk with intellectual disability. Does At this point, I'm gonna probably move over and do some questions. Does anyone have any uh, before I go to question and answer? Does anyone have any concerns, questions, or comments about this case? Alrighty, I will go to the questions. Um, we actually ran this case through AI, ChatGPT, and came up with 5 questions. And I have some additional questions. Um, so let me go to the questions. And some of these are they're a little, the answers were a little weird, but there's still learning points that we can take from them. So the first question regarding this particular case is, which adverse effects is most likely responsible for the patient's complaint of feeling unsteady after starting risperidone? They give us 5 choices here: orthostatic hypotension, akathisia, tardive dyskinesia, neuroleptic malignant syndrome, and sedation. Now, the answer that these guys gave was B, akathisia, but that's not the case here. Uh, uh, Akathisia is more of a nervousness, restlessness, tremulousness that patients may have after being placed on a neuroleptic, particularly the typicals. Um, but this case here, more with the shuffling, unsteady gait, is more of an EPS Parkinsonian situation. But I'll go ahead and read the answer that AI gave. Feeling unsteady or restless after starting risperidone often indicates akathisia, and this is an extrapyramidal side effect characterized by inner restlessness and inability to stay still. Orthostatic hypotension and sedation can cause dizziness, but typically lack the compelling motor restlessness seen in akathisia. Tardive dyskinesia and neuroleptic malignant syndrome are generally late or severe complications rather than early onset effects of initiating a neuroleptic. So TD's late, NMS is late, akathisia is early, and orthostatic hypotension and sedation can come on early too. They didn't offer the answer uh, of Parkinsonism, so that wasn't a choice. But this is definitely a case of Parkinsonism and not akathisia. All right, we'll go to the next question. All right, what is the most appropriate initial intervention for managing the adverse effect um, of this adverse effect of akathisia? So discontinue risperidone immediately, add a beta blocker such as propranolol, reduce the risperidone dose and monitor, switch to a typical antipsychotic, or start an SSRI. I would I would I would go with C. I would reduce the risperidone and monitor. Let's see what they give as an answer here and the explanation. All right, C was right. Reduce the risperidone dose and monitor. Um, for mild to moderate akathisia, initial management includes lowering the dose to reduce the dopaminergic blockade while preserving the antipsychotic effect. Immediate discontinuation risk in destabilizing the psychiatric symptoms, and switching to a typical antipsychotic would likely increase the EPS. Um, um, so you don't want to just stop the medication, nor would you want to move from an atypical to a typical, which would really increase the EPS risk. If symptoms persist, adjuncts such as propranolol or benzodiazepines can be considered, but dose adjustment is the safest first step. So, um, if you have akathisia, reducing the dose doesn't uh, um, um, improve the situation. You can add a little bit of propranolol or a little bit of a benzo to improve that agitation or tremulousness, that inner restlessness. Um, let's go to the third question here. All right. Which of the following best describes the mechanism behind risperidone-induced extrapyramidal symptoms? You got five choices. A, increase serotonin activity in the frontal cortex. B, dopamine D2 receptor blockade in the nigrostriatal pathway. C, enhance norepinephrine release in the locus coeruleus. D, GABA receptor antagonism in the basal ganglia. E, glutamate receptor modulation in the hippocampus. I say the right answer is B, as we talked, D2 receptor blockade in the brain, particularly in the nigrostriatal pathway, is what causes EPS. See what the official answer key says. Um, Antipsychotic induced EPS arises primarily from D2 antagonism in the nigrostriatal pathway, which is critical for motor regulation. Agents with stronger D2 affinity, including risperidone at higher doses, will produce more EPS. Other neurotransmitter systems, such as serotonin, norepinephrine, GABA, and glutamate, do not explain EPS pathophysiology. Okay, go to question 4 here. Um, which patient factor increases the risk of developing EPS with risperidone? Um, um, you got younger age, female gender, history of substance abuse disorder, advanced age, or history of high blood pressure. So, which one increases the risk? Which factor increases the risk of EPS? I say the answer is D for D, advanced stage. Let's look at the answer key here. The answer is advanced age. Older individuals, older adults with increased susceptibility to EPS due to age-related dopaminergic changes, comorbidities, and altered pharmacokinetics. So the older you get, the more sensitive you are to these antipsychotics. Younger age is generally protective, and gender differences are not consistently predictive. So, as far as EPS, gender is not an issue. But I've heard that with tardive dyskinesia, uh, women are much more sensitive, or develop TD more so than elderly men. Um, Substance use history and baseline blood pressure have limited direct association with EPS risk compared to advanced age. Okay, so those are non-factors. We got one more question in this particular set of questions here. Um, uh, if the patient continues to experience significant motor side effects despite dosage adjustment, which antipsychotic would be the best alternative to the risperidone? Haldol, clozapine, prolixin, uh, thorazine or chlorpromazine, and geodon. So you got those five choices. I would probably go with ziprasidone um, before I do the clozapine because of the extra workup and management you got to do with the clozapine. But the correct answer on this answer key is clozapine, clozaril. Clozaril has the lowest EPS liability among the antipsychotics because of its weak D2 blockade and distinctive receptor profile. Typical antipsychotics, such as Haldol, Prolixin, Thorazine, carry a higher EPS risk. While ziprasidone is an atypical, or geodon is atypical, its EPS risk does remain higher than that of clozaril, making clozaril the preferred alternative for persistent motor side effects. And if you're going to use clozaril, just make sure you have the requisite resources to manage to manage using that um, agent. Alrighty, I'm gonna try to do a few more questions since we got a little bit of time. These questions are going to dwell more on intellectual disability, hammer some points in about that. And let's see. I'll go over some key points um, about go over some key points about um, intellectual disability. Two pieces of information are needed to make a diagnosis of intellectual disability: evidence of deficits in intellectual functioning, both clinically and via standardized testing. That's one set. And then evidence of deficits in adaptive functioning. So you have to just get a gross measure of someone's intellectual capacity or cognitive capacity, and then you have to look at how that impacts their functioning in the environment. Those are the two ways we make a determination of ID, and that helps us with the staging. Um, in individuals with moderate to profound intellectual disability, it is important to remember that medical conditions causing pain can result in aggressive or self-destructive behavior in an individual with a limited means of communication. So, if someone's getting really agitated and they can't really tell you that, and they have ID, they're probably going to act out aggressively, physically, and so that should be one of the top things you need to look at in your evaluation of that behavior. The impairment associated with intellectual disability is global and fairly consistent across all areas of functioning. So it's not like they have a learning disability where math, writing, reading, they're globally they have global cognitive impairments in all spheres. Intellectual disability is common in patients with autism spectrum disorder. Appropriate assessment of intellectual functioning in autism spectrum disorders is essential. Intellectual disability is characterized as a neurodevelopmental disorder, distinct from a neurocognitive disorder, which is characterized by a loss of cognitive functioning. So, if you're going to have intellectual disability, it occurs early on in life as you're acquiring cognitive capacity, as opposed to dementia or neurocognitive disorder, where you actually start losing cognitive capacity after a peak has been attained. All right, we'll do just a couple questions here. Patients, patients with which level of intellectual capacity are capable of holding a job? We got answered all levels, mild only, mild intellectual dysfunction, mild and moderate, the C, severe, moderate, and mild, uh, answer D, and answer E is individuals with intellectual disability are unable to hold jobs. The correct answer is B. Only people with mild, generally people with mild um, intellectual disability can hold a job. If they're moderate, severe, or profound, they won't be able to do that. Uh, Although persons with all degrees of intellectual disability can require some support to function in the community, those with a mild intellectual disability are only able to hold a job. Individuals with moderate intellectual disability are often able to manage small amounts of money and they can make change. Persons with severe and profound intellectual disability have limited abilities to manage themselves and have difficulty learning the skills necessary for keeping a job. Um, another question here: an 18-year-old boy who has benefited from training in social and occupational skills, but has been unable to progress beyond the second grade level in academic subjects. All right, he needs supervision, guidance when under mild social or economic stress or requirements. Which level of intellectual disability is being described? So we have a guy here that's unable to move beyond the second grade level, uh, and he needs supervision and guidance in in dealing with financial issues and other social situations. Choices are mild, moderate, severe, profound, and then borderline level of intellectual functioning. The answer here is C. Also, although each of the conditions listed is associated with intellectual, I mean, correction, the answer here is B, moderate. B, moderate. This description refers to a person with moderate intellectual disability. Um, um, and there's a table that describes each feature to match the his presentation up with uh, what's expected to put him in that moderate class. Alrighty. Anybody have any questions or concerns or any cases similar to this that they would like to ask a question about?
Dr. Brown, I had a question about the case study. So
All right.
you said that it was definitely Parkinsonism. And how did you determine that as opposed to the ekathisia?
Because of the shuffling gait, um, people with akathisia, when they sit, they kind of, it's two different presentations. They just kind of are tremulous and kind of tapping their toes, and they don't have the bradykinesia or the slowed movement. They're moving pretty quickly, but they're tremulous. The people with Parkinsonism, they're very slow. They're not tapping their feet because they have bradykinesia, so they kind of sit in a block, and they're very slow to get up. They're not, if they have any tremulousness, it's more of the Parkinsonian rhythmic. It's just not very fast beating, and they're not tapping their feet or moving their legs, stretching, and all of that stuff because they're more in the Parkinsonian mode. So if you think of akathisia, think of fast moving motor activity, and then think of Parkinsonism as just bradykinesia or slow motor activity. That's kind of how I divide it up. So if the patient's sitting there moving around, they can't keep still, akathisia. If they're sitting there and not moving, kind of staring, um, not adjusting their feet, and then when you see them walk, they're taking slow steps and they're not walking very fast. I would consider that Parkinsonism.
Oh, that's a good way to distinguish it. Okay.
All right, you
Thank
get
you.
it?
Uh-huh,
All right.
yeah, I understand now. Well, and then the medication you said, it said Clozaril, right? But you said you would have picked something different?
I would, yeah, because we're out here dealing with situations where there's not a lot of resources, and getting that blood work, every 2 weeks and every month and tracking it, that may be a challenge, you
Oh, it
know.
usually is. So what would your choice have been?
Well, in there they had Ziprasidone or Geodon. I would have picked that, but typically I would just go to something like Seroquel or or um or Zyprexa. And the lady, she's kind of underweight. I think she was like 142 pounds or something. She's real, so she's short, but I think she could put a little more weight on. So I wouldn't be too worried about that. She's real slight, so I'd put her on Zyprexa or Seroquel. And I probably, you could take the Risperidone down. I'm not even sure why they put on that high dose of Risperidone in the first place. That's a lot of Risperidone for someone who's 4'8" and weighs 142 pounds. So really, probably just going down on the Risperidone to a lower dose, maybe 0.25 or point 0.5 a day would have done the trick.
Okay. Okay,
Okay.
thank you.
Dr. Brown, how about adding cogentin with that, with the risperidone?
Uh, well, since it's you could, but the best thing to do is try to go, as opposed to going to two medicines. The best thing would be to try to just stay on one and reduce it to a dose where it doesn't cause any side effects. Because when you add the cogentin, it's anticholinergic, and if you kept her at the same dose of Risperidone, she's going to be shuffling, and then you add cogentin, she's going to be shuffling and dizzy and sedated. So you're going to get a worsening of her clinical situation. So, um, and I would only use cogentin or Benadryl when someone has the EPS symptoms of dystonia, which is an oculogyra crisis, where their eyes are rolling up, or their neck gets tight, or their head turns to one side. That's when you would use, a Benadryl acutely, and you may want to add some cogentin if they're having that particular symptom set. But since she's not having an acute dystonic reaction, and she's having more just a Parkinsonism, the best thing to do is just to, you know, try to take that agent and reduce it down to its lowest dose that doesn't cause any side effects.
Okay, thank you.
Hmm. Any other
Uh, once we re-
questions?
once we
Oh, go ahead.
reduce it, once we reduce it, when would the follow-up be?
Um, I I'd probably have her come back in a week to 2 weeks just to see. Yeah, I mean, she should get better. If you reduce the dose, you should see some improvement within, I say within a week, you know. And like the author said, just make sure that you restrict her from walking and climbing up steps, climbing down steps, all that stuff until, she's clinically stable. But it should take about 5 or 6 days for you to see an improvement in that side effect. The Parkinsonism is, I would say, is pretty dose correlative. Some of the other symptoms are not. EPS, it just happens. Tardive dyskinesia, it happens. Anesthesia is probably dose responsive too. You could reduce the dose down in that and get some improvement in that symptom set.
Okay, thank you.
Mhm. Any other questions from anybody else on the behavioral issues? What are some of the other medicines other than risperidone that could be used to manage the disruptive behavior? Other than, would anybody consider using a mood stabilizer? Depakote, Lamictal, Tegretol.
Yeah, Depakote.
Yeah, you consider. I'd probably use a little bit of Depakote. 250 BID.
Mm-hmm.
Yeah, that'd be another option. In this case. Alrighty. Well, it's about 8:20. Any other questions? I got a whole bunch of questions, but I don't want to beat you up with that. Um, I think y'all got the gist of it. So yeah, went over a little bit of MR, went over a little bit of impulse control disorder, even though this was non-specified, and we went over some EPS symptomatology. So that's a 3-for-1 right there. Anybody got anything else that they want to discuss or bring up? Well, if not, everybody have a Merry Christmas, Happy New Year, and I will see you. I'll talk to you guys. Well, I guess we'll be looking at each other in January, okay?
All right, thank you.
All right
Thank
then.
you.
All right.
Thank you.
All right. Bye-bye.
Okay, bye-bye.